This is a 65-year-old gentleman from Coimbatore. His chief complaint was storage and voiding lux for 2 months and hematuria 1 episode 2 months ago.
Next type for elaboration of storage and voiding lux, which type of means frequency or urgent?
Yeah, good, Hardik. This is how you keep moving, okay? We will stop if we require something, we need to see something or ask something. Yeah.
Patient had frequency, urgency, urge incontinence, and difficulty in voiding, dysuria, incomplete evacuation, along with weak urinary stream for the last 2 months.
What do you mean by urgency?
So the patient has difficulty in controlling the act of micturition, sir.
What is the ICS definition of urgency?
Sudden, difficult to differ, compelling desire to pass urine, sir.
Sorry?
Sudden, difficult to differ, sir, compelling desire to pass urine.
Sudden,
difficult to differ, sir.
Compulsion,
difficult to differ,
to pass urine, which if postponed, the patient feels may lead to leak.
Yes.
Okay, good for you to know this. What is urgency incontinence?
It's involuntary leakage, sir, accompanied or immediately preceded by urgency.
Preceded by urgency. Good. Now put the storage and the voiding symptoms separately, Soumya. I told you last time also.
Yes, sir.
All of you. Put them separately.
Yes, sir. Yes, sir.
Okay. Yeah,
patient has a storage and voiding. Hematuria, it is a gross or microscopic?
Because gross hematuria.
Okay, and painless or painful?
Painless.
See, this question, Hardik, is useless in the exam. Painless or painful. Okay. Painful hematuria for 2 months won't be kept for exam.
Yes.
But it's good for the person who makes the presentation to say painless hematuria.
Yes.
Yeah.
Any history of fever?
No history of fever.
Ask them if they have any more history of preventives.
Any more positive history or negative history?
No, sir. Negative history is there in the next slide, sir. This much for
No. See, for all of you guys, history is divided into history of present illness and other history. Correct? So, history of present illness will include all this. Whether he had pain, whether he had fever at the time of hematuria, excuse me, and so on. Other history will be whether he is diabetic, whether he gets frequent fever, whether he has that or this. But where there is urgency and dysuria, we should ask whether he is ongoing fever, because that adds to the diagnosis. Okay. So, how do you ask questions? Ask questions accordingly.
So you see, since we are discussing ICS, there are 2-3 terms which are wrongly used. One is dysuria, should not be used.
Yes, sir.
Weak urinary stream, the ICS usually says poor stream rather than weak urinary stream. So better to use proper terms. And whenever there is hematuria, write one sentence: total, gross, painless, intermittent hematuria, or whatever, something like that, rather than creating doubts in the mind of the person who is reading it.
Yes, sir.
Dysuria, historically in urology and English, has meant inability to pass urine, not painful micturition. So say painful micturition, burning micturition. What do you want to call it? Morning, Prabhu.
Morning, sir.
Morning.
Morning.
Good to have you back.
Yeah, what to do? These guys, all these Manish Chelas go all over Bangalore looking for all kinds of dust, powder, crystal, liquid, everything and pumping.
There is no history of fever. There is no history of nausea or vomiting. No history of breathlessness or hemoptysis. No history of bony pain or any limb swelling.
See, relevant to the case, you should ask negative history. Now, I agree, fever. Whether he had nausea, flank pain, that is more relevant in this case. Or what treatment this patient received in the last 2 months, that is more relevant rather than, you putting breathlessness, is possible, but be specific to the case.
See, supposing Hardik, I ask you, patient has breathlessness and hemoptysis with hematuria. What will your diagnosis be? You see, you get stuck, isn't it?
Yes.
So, Soumya, don't put all this. You can simply say no other symptoms. But
Yes.
mention specifically no abdominal pain, no renal angle pain.
Yes, sir.
Okay.
Any history of any catheterization or past history?
Okay, tell me, what does catheterization have to do with hematuria several years later? It's not relevant at all. Catheterization is relevant if a young person, male, has recent onset difficulty in passing urine, and one of the reasons could be a catheterization induced inflammation or injury. A 65-year-old man, if he had catheter some 40 years ago for hernia surgery, what does it matter? Somehow it has got ingrained, catheterization, instrumentation. Tailor it to the case being presented. If there was any of that, they would have told you in the presenting complaints. Okay, Hardik?
Yes, sir. Yes.
Yeah. Go on.
So, on this left upper limb surgery, you should either give some information because is it relevant to this case or was it traumatic? What is it about?
What was the surgery?
Sir, actually documents were not available, but it was for some trauma he had undergone surgery, sir.
No. See, here's where somewhere you need to take and present as much of the history as you can get from the patient. He will
Yes.
tell you if it was injury, I had a fall. If it is a vascular episode, he will tell you I suddenly developed pain and numbness, and they said there is a clot. That becomes relevant in another context, but since there is hematuria, we don't know whether he is on anticoagulants. Right?
Yes, sir.
Yeah.
So, if it was a fracture, you would have been on immobilized for a couple of weeks or months. It's simple to understand what it is. Anyway.
Personal history. The appetite was normal. Occasional constipation. History of smoking for the last 40 years. And a history of alcohol consumption was also present.
What do you begin with in personal history?
So, appetite and food
No.
habit.
No. You begin with whether he has a family, how many people, whether anybody else had hematuria in the family, died or is suffering from renal disorders. All that is personal history. And then you come to these things which are physiological. Okay.
Yes, sir.
Because that's where you'll also get whether he has enough social support, monetary support for his treatment. Yeah, Hardik, go on. I mean, this is for
Any-
someone, not for Hardik. Go on.
Any history of drug history? Any for the lower urinary tract he's taking? He was
Why
taking
only
any,
lower urinary tract? He
also
can
for
take a drug.
hematuria.
He can take a recreational drug and have all this. What you
Any
want
visit to a
know,
local doctor or hospital?
Are they? Listen, what you want to know in an exam, 20 minutes is all you get. You want to know whether he is on any medication and if that medication can be related to hematuria. Correct?
Yes.
So ask the specific question, what medications is he on?
Any hello?
Hello.
Any history of medication is taking for hematuria?
No such.
Not for hematuria. The medication
Means that
might
causes
be for
an antiplatelet or any.
No such medications.
Okay, before going to differentials, what are your different? What are your before going to examination? What are your differentials?
So patient with 65 years male with
Don't
storage.
repeat all that.
No,
Just
just
tell
all
me.
that. Just say my differential diagnosis is
My differential diagnosis
154
is
or whatever.
benign enlargement of prostate, sir. Then urothelial carcinoma, transitional cell carcinoma of bladder, CA prostates.
Sudden onset. What else can it be?
Anything more? Start from common to dangerous or rare causes.
He's got severe dysuria, urgency incontinence. And if you ask
Neurogenic.
him, maybe he'll tell you, yeah, my difficulty in urine happens sometimes all of a sudden.
Why did you say neurogenic, man? What are the things? Can it be vesical calculus? Can it be recurrent UTI?
Sir, hematuria with sir Lutsum and the age is 65 years, sir. So mainly benign enlargement of prostate, carcinoma.
It's okay, but don't you get bladder stones at 65?
Yes, sir. Bladder stone.
But it's not unusual.
Then
There may
BP
be a BPH along with that.
with
there may-
vesical calculus.
Yeah, so mention vesical calculus when there is so much urgency and incontinence.
Okay, sir.
Can there be any other bladder pathology which can account for all these bloods, apart from malignancy and all that? Any other bladder pathology which concomitantly occurs in quite a lot of these patients? Benign condition, so we say benign pathology, but people don't think about it all the time.
It infection in forms of genitourinary tuberculosis.
Dr. Prabhu has already said infection and all the rest of it. But this is the pathology that occurs in the bladder. And as a result of this pathology, all these symptoms can be coexisting. It's not malignancy. I tell you, it's a benign pathology. It's enough to produce all these symptoms of urgency and blots and associated with BEP. Don't forget bladder diverticulum, alright?
Yes.
I keep telling all the residents, please don't forget bladder diverticulum, and anybody at this age who's got blots, you're not sure what the problem is. All this hematuria can be there, even with the bladder diverticulum. The tumor inside that diverticulum, the pathology is basically diverticulum large, which causes all these symptoms. You have not seen? Large diverticulum with BPH is very confusing.
Yes, sir.
Don't know what is the cause of the problem, which came first, chicken or the egg situation. Okay.
Abdomen soft, non-tender. There was no mass or lump palpable, no organomegaly. Bowel sounds heard. DRE could not be done in view of severe perianal pain, presence of fissure in ano, genitalia, prepuce retractable, glands and shaft normal, meatus normal, both tests is normal.
Tambi, when you presented, you simply said he had constipation. I was also waiting to see whether you'll add anything to it. Huh? Don't you want to find out at that time whether constipation is associated with anything else? He's got so many anorectal conditions now. Why does he have fissure? Hardik?
Maybe constipation, sir.
Correct. Why does he have constipation? Maybe due to fissure. Okay, elderly man presenting with constipation, the constipation may be more serious than his hematuria. One episode. Okay, so Soumya, you have
Yes,
to join the dots, man, when you make this presentation ready.
Yes, sir.
Okay, it's a narrative, it's a story. Okay, he also has constipation associated with perianal pain. And the constipation, how do we classify? Is there any classification? The pediatric urologist uses a lot, but it's applicable to adults also. Hardik?
Sir, I want, investigation, blood investigation.
No, wait.
He wants to know about the constipation.
We want to know how severe the constipation is. Is there any way in which we can quantify it?
All European country name.
Yeah, Bristol scoring system, sir.
Yeah, so Bristol's to
Two per scale.
so that will give you an idea. If it's
Rome
not
four rating.
mild constipation and the grade 3 stools, that would not be a big thing. But if it's got grade 5, passing rocks once in a week, then the causes might be very different. You get it?
Yes.
Are they? So, old man with constipation is no joke. Yeah, let's move.
Blood investigation, HB is 14.8 and serum creat is 0.66. Total count?
No, that's all right, don't worry. Of what is given here, any important abnormality or
No, sir.
any important normal finding. Look at it carefully.
So, normal, sir. Hemoglobin.
What is important? Something important in this. We don't expect
Want
it
to know what is the important normal.
See, hemoglobin 14.8, but he had only one episode of hematuria, sir, not a continuous or cross hematuria that leads to pallor or decreased hemoglobin on blood investigation, sir.
at 65 years. Can any of this be deranged by a natural process of aging?
That question is easy enough to answer, isn't it? Which of these blood parameters correlate with aging?
Increase uric acid, sir, with
Uric
age.
acid, no. Uric acid has got no relationship to aging. Uric acid, the amount of uric acid that is produced, most of it is from the diet that we take. And if you do have a congenital problem, yes, but It is not reflected there. Aging does not cause a change in uric acid. Which organ in the body ages in any of these blood tests which are shown? Baba, the kidney, isn't it?
Kidney, yes, sir.
The GFR after the age of 40 will drop by 10 ml per minute for every decade of life.
And at 65, this guy is about 90.
Just remember that from the age of 40 onwards, the GFR drops by 10 ml per minute for every decade of life. There are some variations, some books write something, but this is easy enough to remember. Okay, so this fellow's creatinine is good. The GFR is 90. He's got pretty good kidneys. In spite of all the alcohol and the cigarette and everything, hope for many people. So that's the question that Mohan wanted you to answer, Hardik. You got it?
Yes.
Yeah.
Yes, sir. Urine examination.
So, may again,
Yes, sir.
in correct order. Urine examination comes first before the serum biochemistry. That is why we know so little about interpreting urine examination. We all assume that report is in the file and leave it at that.
On urine examination, sir, RBC present 8 to 10 cell in microscopic urine. Patient have microscopic hematuria.
Hardik, why do you
Liver
want-
function test is normal, sir.
Why do you want the liver function test? There was nothing on examination which warranted a LFT.
Yes, sir. At present, no, sir.
No, you have to think quietly. You have said liver function test.
Normal, sir.
I told you why. Think of quickly a reason why you want to do a liver function test and get out of this. Get out of the trouble you're in. You only ask for liver, isn't it? This fellow has had history of alcohol consumption. He's been going on for a long. Think of it may not be anything, but you have to get out of the mess that you have created. So wriggle out of it by saying that this guy is an alcoholic, sir. I don't know what is
Maybe.
whether he's got
Yes.
any problems. I just want to have a look at it. Nobody can fight you on that. If you just routinely say liver function, you will be pounced on.
Yes.
Liver function is a very costly test. This entire battery of tests is pretty expensive. It's not 10 rupees or 15 rupees. This entire panel of liver function tests is very expensive.
1400 in Bangalore.
No, it is very expensive. So, that's why some people choose specific liver function tests to know exactly what the situation is. And if you've got obvious liver disease, then you can. The entire panel here is a problem. Anyway.
Why was uroflowmetry required?
Sir, as a part of workup of LUTs, sir, he had difficulty in voiding.
Your protocol to do.
His flow was not normal.
He's telling you flow is then not normal. What will uroflowmetry show? Same thing.
So
Wriggle out of it.
So the pattern is important.
No. Wriggle out the pattern is something that is very variable. Wriggle out of the situation. I don't know whether Hardik is supposed to answer that question.
Hardik.
Sir, it will helpful on follow up the patient to improvement with the medication.
It's a baseline in case there is obstruction.
Yes.
You're justified in doing that. But don't ever say to make a diagnosis.
Yes.
The parameters which are there in the uroflowmetry will help you to understand some of the problems in the lower urinary tract, trying to correlate it with the symptomatology. Most importantly, if this man has got so much of lux, you will know at least what his bladder volumes are. Maybe just one of those. And you will also know whether he's got a post-void residue, depending on bladder volume that he passes. So you have to think of a way by which you have to answer the question.
I think if you look at the results,
So,
Yes.
look at the results.
Sir, maximum flow rate is 2.1, average flow rate 0.9, sir. And voiding volume 579 ml and post-void residual 174 ml, sir.
How much is avoided?
Voiding volume 579, sir.
It's 57.9.
50.
So voided volume 67.9 ml.
Okay.
So what is the problem with this voided volume? In terms of urodynamics.
I think
Next has asked this so many times.
what is the issue related to this?
It's in this curve, sir, average flow rate is equal to the maximum flow rate with prolonged tail of passing urine curve. So it is suggestive of, sir, plateau pattern of flow.
What
And
are
voided
the
volume is
requirements?
less than 150 ml, sir. So
Are they? What are the requirements of a Euroflow interpretation?
more than 150 ml volume should be voided by patient, sir, to good quality of UFR, sir.
It is because
Ideal.
invalid. Now they are
Yes.
showing a PVR of 174. What are you concerned about? Why did he say this much PVR is 174? Total comes to 230 ml, which is not a huge thing. What's your concern?
Patient here, sir, obstruction to
No,
means outlet obstruction is not able to void.
do something else. In terms of urodynamics. Okay. Only in
Maybe, sir, underactive that too.
Don't make diagnosis. Interpret. Urodynamics is for interpretation. It forms part of diagnosis later on, along with all other things. We never make a diagnosis based on urodynamics study. See, our worry is we don't know whether he's always voiding only around 60 ml, in which case his bladder capacity is small, or whether they said, go pass urine and come, he just went in whatever he had, he passed and came. In which case, this is not a truly representative void. He might be holding 500, 600 ml, but at that time, before coming to hospital, he voided at home, there wasn't much in the bladder. Okay?
Yes, sir.
So these are nuances we need to look at. Whatever the lesion or pathology is, a small capacity bladder is a problem.
I think what is important here is that apart from the fact that his voided volume is very low, he has got a very significant post-void residue. So
Yes.
technically speaking, his bladder volume is 174 plus 67. So he has every reason, if he was a normal fellow, to have had to have a flow rate which could be interpreted, because you need about 150 to 200 ml to interpret a flow rate. But in spite of that bladder volume, in spite of that volume being inside his bladder, he was not able to expel it. Alright?
Yes, sir.
You got to look at the entire picture. And therefore, when you have a PVR at 174, this needs to be rechecked. Always a post-void residue is rechecked. Supposing the PVR on this bladder volume was only 10 ml. Supposing we say that he passed 67 ml, the PVR was 10 ml. Now that could be This guy coming to the OPD having passed urine at home, in hell of a hurry to do the test, and therefore he goes and passes. Whatever is there, he gets an urge because his initial desire is low. At that point, he goes and passes urine. So that's a sort of fellow, you will say go home and come back again with a better flow. This is the sort of fellow you'll be very careful. You
What
want
is
to
the
check that.
ICS
You want to check that.
recommendation?
You see the difference between all these tests which are done. The interpretation is very important.
48 hours of frequency volume chart is also helpful in
Rick.
this type of patient, sir.
Rick,
Sir.
can you hear me?
Hello.
Rick,
Sir.
you can hear me. What
Yes,
is
sir,
the
yeah.
ICS recommendation for a proper uroflowmetry?
Sir, body volume should be more than one.
Authoritatively, you can interpret it.
Sir, body volume should be more than 150 ml, sir.
What else? Is there anything about the number of uroflowmetry tests to be carried out before interpreting? ICS recommends 5.
Okay.
It has modified it to say at least twice you must do a uroflowmetry to avoid these kind of artifacts creeping in. Okay?
Okay.
The other important thing that is, when you see a flow pattern, the first question you ask is, the patient, is this how you would normally pass urine? Or can you do better than what you have done today? You must ask the patient those questions. If he says he can do better, all right, give him another chance, let him do better. If he says that this is how it is usual, then you look at all the parameters and decide whether this is an interpretable flow rate depending on his symptoms.
You might tell you I don't even pass this much.
So, these are very important questions that have to be asked when you're looking at it. So remember, before you look at anything else, any value, ask the patient, is this how you would normally pass urine at home, at the toilet? Then you can do it. And then record on that flow pattern that he can do better. Patient says he could do better.
Yes.
Right.
I also want USD kidney ureter bladder with prostate and see for the post-void residuals.
Well, but he's got hematuria. Why are you concentrating on this? This fellow has got hematuria. You forgotten that. Eh? You've been sidetracked to all this PVR and all that, and you're concentrating on this. He's got hematuria. He's a smoker. You made some differential diagnosis.
Sir, it also.
You don't want to look at other abdominal organs. He's got constipation. You don't want to look at other abdominal organs. KUB will do.
Yes, the abdomen. We can, sir, tell directly in case of hematuria for CCT.
No, that's a different thing. You're doing an ultrasound. How will you maximize the output from the ultrasound?
To see, to rule out, sir, lower urinary pathology.
How will you maximize the output or the information you get out of the ultrasound in a 65-year-old who's got both constipation and urinary tract complaints like hematuria, ruts, etc. His urinary problems are not his only problem. I would be even more scared of his other problem.
Sir, I also like to execute to see for the bowel gas, sir, to constipation to rule.
You see, one of the funny things about colonic carcinoma is that it metastasizes all over the place before it gets discovered either clinically or by examination or imaging. So get a full abdomen scan done, see how the liver looks, see whether there is an identifiable mass in the colon, which often you can identify if it's large enough. Why stick just to KUB? After all, he has to move a few centimeters cranial and diffuse centimeters caudal.
Yes. Yes, sir. USG abdomen plus pelvis.
Not KUB, USG abdomen, including prostate and residual. I don't
Yes.
know where these fellows introduced this. This was introduced by hospitals to reduce cost and increase our throughput, I believe. I can't understand how we can look only at the KUB except on follow-up. A baseline ultrasound should be the entire abdomen. Ganesh sir,
I agree with you. I don't think this can be changed. It's now ingrained in everybody.
Yeah.
KUB. It comes as an automatic default. Ultrasound KUB. So it's like gynecology doing only ultrasound of the pelvis.
and thank God for that.
And missing out a hydronephrotic kidney which they discover after they have done something else.
After there's some leak.
Hmm.
Okay. Here's the image.
On the right side, second last image, sir. In the middle image, sir, kidney, not left or right, but it is a normal size and shape with a normal equitex, no hydronephrosis, and CMD is maintained, sir. In the last image, sir, bladder is thickened bladder wall in the posterior wall, sir, and no internal echos.
No, the first thing you must know about this bladder is the fact that it is not filled properly. One of the requisites in an ultrasound is that the patient is expected to hold the urine. Now, there may be very reasons why he cannot hold the urine. So the first thing you must say is that it's difficult to interpret this bladder simply because it's underfilled.
Yes.
This particular gentleman should have had at least about 200 ml in his bladder, considering that his flow was 56 and 67 and PVR was 174. So there should have been at least 200 ml. But you would like to have a nice distended bladder if possible. And therefore, when you make that opening statement and say the bladder looks a little underfilled, sir, in this patient for accurate interpretation, this is what I can see.
Yes, sir.
Try not read the images rather than try to make a diagnosis. Am I looking for something? No, read the image completely first. Then you come to whatever diagnosis you want to make or cannot make. Very important. So what do you make out of the ultrasound?
So small right side in the right lateral was hypoepic structure is in
Where? Right lateral wall.
sir.
Where? In the bladder or?
In the bladder, sir, in mid that sir.
Though traditionally the report begins with the kidney, bladder gives you the best imaging window. So good to start looking from the bladder and then go up. And if he's got hematuria, there's an even chance that he's got lesion in the bladder or at the outlet. You get it, Hardik?
Yes, sir.
In fact, many of our old radiologists are very good at this. You say the patient has got hematuria or lower tract symptoms. The description in the report will begin with the bladder. And then they'll go on to say, kidney was this, kidney was that. Yeah.
Yes.
You think that the mass-like lesion which you have talked about is part of the bladder, or is it part of the prostate, or what is it?
So it looks a part of the bladder, sir. Oh,
Look at both axes. Look at sagittal and coronal. Don't jump. Let him first make a diagnosis on ultrasound. Please, guys, don't jump. Go back. Soumya, go back. Yeah. He has to tell us his findings.
Sir, it is suggestive of hypoechoic structure approximately 1.5 to 1 centimeter.
It is there. This is what you are seeing. It's all right. Others might see something else. There is a 1.5 or whatever into whatever.
On the right,
Or hyperechoic structure.
with in the right lateral wall of the bladder with wall thickening.
Are you looking at the sagittal section or the coronal section?
The last coronal section, sir.
Yeah, so where is the right or left in the coronal sections? You are seeing it at the outlet, correct?
Yes.
At the apex of the bladder. So, to know left or right, you have to look at the transverse section or the axial section. Okay, anyway, let's move on. Where is the ultrasound report, boss?
Ultrasound report?
So it's only the pictures we had. He had done the ultrasound outside actually, sir. He had come only with the pictures.
What was here in the
Come with any report. God knows where the report was, but he came just like that.
Soumya, what was your interpretation?
So there was no lesion in the bladder, sir, on seeing the ultrasound. And the wall looked thickened.
Was there anything in the kidney to account for hematuria? Don't forget this fellow had hematuria, man. You have to look at kidney, bladder, everything. In the bladder you can't see, then go up and see whether the kidney has got any tumor inside it. Is there any hydronephrosis? Even though he's got normal renal function, he can still have hydronephrosis. All those things can be easily interpreted, even though the quality of the ultrasound is not the world's best. Whatever it is, whatever you're seeing here.
Why have they done an RGU MCU?
So the patient had voiding lung, sir. His
So 80-year-old patient with
Stream
voiding
was,
nuts will do an RGU, is it?
no, sir. Stream was very poor, and in uroflowmetry also.
Correct. That's what I'm saying. Stream poor is voiding nuts.
Yes, sir.
We'll do an RGU.
So the uroflowmetry suggested
No, will we do an RGU because uroflow is poor in a patient with benign prostatic enlargement at 80? You got a grade 3 prostate and rectal examination, and you want to do.
so rectal examination was not possible. So
I am asking Hardik. There is a 80-year-old patient who has a grade 3 prostate on DRE. Will he do a urethrogram?
No, sir.
Then why was it done? Ask Soumya. Why was it done, Soumya? I can see one reason.
So,
No, whether it's true.
so DRE was not possible.
Not DRE, the urethrogram.
Sir, patient has a significant post-void residual with voiding LUTs severe to rule out stricture disease, sir.
I won't accept that. At 65, you want to look for stricture disease by doing a urethrogram.
We should, sir, first do calibration with 16 and full it.
What is more likely at 65? Stricture or benign prostatic disease or any prostatic disease or obstruction? When will you suspect a stricture? That is the point you're missing. I see something here which I reasonably accept if you say this was the reason why we did the urethrogram.
To answer that question, you must look at both the history as well as the clinical. If the history is long standing, you probe into that. If his history of LUTS was only really recent versus this history of LUTS which has been going on, or in the past he has had some intervention, this fellow has had a history of surgeries for the upper limb, for the lower limb, hemorrhoids, and all the rest of it. At any point in time was the catheter introduced, anything in the urinary tract which is an instrument can result in a stricture which the patient may not have any knowledge about, and then it can manifest later on. Or if on clinical examination there is obvious meatal stenosis, there is obvious evidence of BXO and things like that, or induration of the urethra, these are the situations where upfront you would be standard. In spite of a DRE being normal or abnormal, you would still have to look at it. So that's exactly what Mohan wants you to say. That, you have got to look at the situation. You can't just, you got to keep thinking all the time, what exactly is the reason why this question is being asked.
You found the XO, you found the meatus abnormal, you're not able to retract the prepuce. Those are situations where you're justified. Okay? It's not done in all people who've got voiding symptoms, irrespective of age. Because this is dangerous, it's not a safe procedure to do. Obstructed outflow tract, people will develop sepsis in no time. Understood, Hardik?
Yes, sir. Yes.
And Soumya?
Yes, sir.
And others? Others are quiet. Shell shocked.
No, I want everybody to understand as to when a question is asked, as to how. I hope you understood the question that Dr. Mohan asked and the reply that I gave. You understand how you got to? It's the same thing like Arthik asked liver function test. Think of the question that has been asked and how. It's not a difficult question in the sense, but it's a question that probes you to think. Why is he asking this question? There must be a reason. So look, it will be there. The reasons will be there.
Yes.
Don't look at things in parrot fashion, Is there very clear like that? No, it's not like that. The purpose of these classes and these exercises is not to make you into a robot. Think about why. Now what are you going to interpret this, man?
Sir, yes, in first images of retrograde RGU on RGU, the anterior urethra looks normal and contrast reaches into the bladder, sir. In a middle image of
Hello. Anterior urethra begins at the meatus.
penile urethra and sir bulbar urethra normal.
No, tell me about what's happening to the terminal urethra. That's what aroused my suspicion of other conditions. And I said, okay, maybe they're justified in doing the urethrogram.
So there is no obvious picture, but the posterior urethra becomes constricted, maybe compressing from the prostate, sir.
Anterior terminal urethra.
That coffee.
Get it done, sir.
Sorry, sir.
No, that was for Dr. Ganesh. You missed it. No, look at the terminal urethra, Hardik. Is it looking regular? Is it descending normally? Is the lumen central throughout? See, strictures are always found in the bulbar urethra.
Sir, it is, sir, not, maybe, sir, enlarged prostate compressing the posterior urethral.
Hey, show him that terminal urethra tip, man. What is there? You begin looking at the urethra from there. This is after all a retrograde urethra. There is irregularity of the lumen with a few outpouchings and eccentricity in places of the terminal 2 centimeters or so, after which the urethra still doesn't distend as it physiologically ought to. That is the interpretation of the first film. The second film, I presume, is a cystogram.
Sir, pushed-up bladder with irregular bladder and irregular bladder.
Well, how did you decide when to stop? In a retrograde urethrogram or during the voiding cystourethrogram, when do you decide the bladder is distended enough for me to stop? You can't interpret the bladder based on an ascending urethrogram. You put in some 50 ml at the most.
In the second image, sir,
Yeah,
system
there's about 50 milliliters there.
with irregular bladder wall and
Samya, I want to know, why did you stop at this volume?
What is so difficult in answering that
so
question?
maybe, sir, patient have a pain or urgency to pass urine.
No,
Patient
so-
not able to hold.
He should
After
tell a
putting
patient
repair.
bladder pain. Now a patient with a painful small bladder is a different kettle of fish from someone who's got a small bladder but doesn't have pain. So you see how the vistas open up.
So we have another meeting here at 9, sir.
Okay.
Right.
Can we-
Take this up next time.
Yeah.
Yes, sir. Can we continue next time, sir?
Yeah.
Okay.
Yes. Sir, and I just wanted to introduce Saurabh. He's joined us
Yes,
from